Shukran. Assalamu alaikum. And now we switch to English. So it's a great pleasure to be here to talk to you about thyroid nodules 2017. And let's start off with a case. Let's take a look at a 28-year-old woman who sees her obstetrician for a routine visit, and they do very good physical exams, as you know. She feels well, except her voice is a bit affected, and she's having difficulty in speaking. Her blood pressure, heart rate, height, and weight are all within normal limits. But on physical exam, she's been found to have a 2.5 centimeter smooth thyroid nodule on the left side. When she swallows, it ascends and descends very easily. But she also has a palpable lymph node also on the left side along the sternocleidomastoid muscle. So the first thing we need to ask ourselves is, do 28-year-old women show up with thyroid nodules frequently, or what is the deal? And the truth is that as we have gone on in life, the frequency with which we see thyroid nodules is increasing all the time. This goes a timeline back to 1973, when I actually did my initial training. And thyroid nodule frequency and thyroid cancer incidence were rather minor. There were not that many found, and thyroid cancer was not something that most endocrinologists dealt with routinely. However, with the introduction of CT scanning and MRI scanning, which was used more and more and more, the frequency with which thyroid nodules were found, as well as thyroid cancer, began to increase. And as of 2008, for example, thyroid cancer rates have increased in the United States at least 5-fold in those under the age of 65, and 8-fold in those over the age of 65. Now you might ask, what's the difference between those under 65 and over 65? Well, in the United States, we have this wonderful system where you don't have health insurance necessarily if you're under 65, but when you are 65 and older, everyone has health insurance. So part of this is access to health insurance and getting a diagnosis. But part of this might also be that there's actually an increase in the frequency of thyroid cancer found in thyroid nodules in the United States. So when we look at the U.S. numbers on how frequently we find thyroid nodules, for example, we're going to find that 30 to 50% of each of us in this room may have a thyroid nodule. And the older we are, the more likely we are to have a thyroid nodule. So people 80 and over are 2/3 likely to have a thyroid nodule. But if we're only going to depend on physical exam to find thyroid nodules, they're rather uncommon. Only 4 to 8% of the patients you see will have a palpable thyroid nodule. Thyroid cancer, on the other hand, is not very common in the big picture. In the United States in 2016, only 64,000 cases of thyroid cancer were found, which translates into less than 1% of the population, so 0.005%, far less than 1%. So if 50% of the population have thyroid nodules and only 0.005% of the population has thyroid cancer, that is, not many thyroid nodules are actually thyroid cancer. The good news is that even if someone does have thyroid cancer, which we're not going to be discussing in detail today, it is a relatively non-fatal type of cancer with only about 5% mortality. In the United States, less than 2,000 people died of thyroid cancer in 2016. Now, as we get older, however, thyroid nodules take on a different meaning. So this is from a recent study from the Brigham and Women's Hospital, where we see that on the one hand, the older we are, risk of malignancy per nodule actually decreases as we get older. So if we have more nodules, per nodule, cancer is found less frequently. But once we find a cancer in an older person, the risk of higher risk malignancy increases. So here are high risk malignancies here, which is very low in the very young. And as we get into middle age, the risk increases a little. But as we get older, the risk of high risk malignancy goes higher. So finding thyroid nodules in older people is very common. However, the number of cancers in those thyroid nodules is lower than in younger people. But if we do find a thyroid cancer in an older person, it probably is more aggressive, so it needs to be found. So there's a lot of work to be done with lots of thyroid nodules out there. So if we take a history from our patients, can we discriminate between those that have benign or malignant thyroid nodules? And most things don't help us very much. Family history of this, that, and the other thing, not very helpful. But if a patient has symptoms of hyperthyroidism, that is a sign that we're probably dealing with a benign thyroid nodule. And there's two studies here, both of which were published within the past 10 years or more, where we see that with low TSHs, the odds ratio for cancer is the lowest, and with TSH values in the middle of the normal range and the upper end of the normal range, the risk of cancer may be 4 times higher compared to those that have low TSHs or suppressed TSHs. And those that are overtly hypothyroid have a nearly 12-fold higher risk of thyroid cancer. Now, I'm not really saying that TSH predicts thyroid cancer, but a low TSH does predict the presence, most likely, of a benign thyroid nodule. In addition to this, we can see that the higher the TSH is, the higher the stage of disease is. So when you're looking at TSH, it is a very important thing to look at as you evaluate thyroid nodules, because it helps you to make a first clinical decision. And that first clinical decision is, should I be scanning this patient to find a hot thyroid nodule that is unlikely to be thyroid cancer? Or should I be ultrasounding this patient to find a nodule that I need to biopsy? So the first question is based on the TSH, and the TSH does help us to divide the waters, so to speak, and to get patients into a low risk of cancer if the TSH is suppressed, or a higher risk of cancer if it's normal or actually elevated. Now, another common question comes up when we talk about, do we have a solitary nodule or a multinodular goiter? Which one is more likely to contain cancer? Well, part of this is simply mathematics. As we said before, as we get older, we get more nodules, and the number of cancers per nodule does decrease a bit. However, if you have a patient with a multinodular goiter, are you authorized to say, don't worry, it's a multinodular goiter, these are all benign? Well, here's a meta-analysis of the world's literature looking at the relative risk of cancer, and it turns out that it's about the same risk of cancer per patient as it is solitary versus multiple. So the patient themselves has the same risk of cancer whether they have multiple nodules or a single nodule. Your job is to figure out which nodule is the cancer. In some studies where iodine deficiency is prevalent in the population, the multinodular goiter seems to have less of a risk of cancer, but where iodine intake is adequate, then multinodular goiters and solitary nodules are approximately the same. So if the patient asks you, since there's more than one nodule, does that mean that I don't have cancer? The answer is no, we don't know that yet, but it is less likely per nodule. But I treat one patient at a time, not one nodule at a time. So if we were to look at a history of things that really should catch your attention and tell you this patient is at high risk of having thyroid cancer, let's look at the following list. If the patient has a family history of thyroid cancer in a first-degree relative, mother or father or child, then, or brother or sister, of course, then they are at higher risk of having thyroid cancer themselves. If they have had external beam irradiation or exposure to ionizing radiation, as in radioactive iodine after a nuclear reactor accident, for example, Chernobyl, they would be at higher risk of developing cancer. Just remember, Chernobyl happened in 1986, and if the individual was 14 years of age or younger in 1986, then they are at increased risk. Most everyone else who was older than that are not necessarily at risk. Surgical diagnosis of thyroid cancer in the other lobe, whoops, that's the one I always forget. And yes, of course, if my surgeon says, well, I took out this lobe and it's got a big thyroid cancer in it, what do you think about those other nodules? You would have to assume that they're at higher risk of malignancy. If a patient has an 18 fluoridated glucose PET scan, and many of our patients have these when they're being evaluated for cancer treatments, and it is a focal uptake into the thyroid, there's approximately a 25% risk of malignancy in focal uptake of PET glucose. On the other hand, if it's a diffuse uptake of PET, then that probably is Hashimoto's thyroiditis. If a patient has multiple endocrine neoplasia number 2 or familial medullary thyroid cancer or is RET proto-oncogene positive, and I don't know whether many patients here in Egypt are on the internet ordering their own lab tests, but I have actually had people come in with lab test results that they ordered on the internet and say, I am RET proto-oncogene positive, what are you going to do? Calcitonins greater than 100 are very much consistent with the presence of medullary thyroid cancer. In the United States, someone coming up with an isolated calcitonin greater than 100 is usually a mistaken blood test, but you still have to deal with it. If calcitonins are high, then you probably are dealing with a thyroid cancer medullary type. Again, the MEN2s, where you find a patient with hyperparathyroidism and a pheochromocytoma along with a thyroid nodule, most likely a medullary thyroid cancer. And then those that have the familial medullary. So as you can see, four or so of these syndromes of high risk have to do with medullary thyroid cancer. Let's move on to another case. So I've got a 63-year-old woman who is seen in the emergency room because she's dizzy. Her vital signs happen to be stable, and wonder of wonders, the emergency room physician palpates her neck and finds a thyroid nodule. The laboratories have been drawn, and her TSH is normal. Good emergency room physician has started the evaluation very nicely. A carotid ultrasound, of course, is ordered because the patient was dizzy. And the carotid ultrasound, of course, finds no obstruction in the carotids to explain the dizziness. But now we have found 3 relatively small hypoechoic thyroid nodules that are described in great detail by the radiologist, and they even do Doppler flow studies. So again, you're the endocrinologist who's going to get the call from the primary care doctor or from the emergency room. Well, we were looking at this dizzy woman, and we found no reason for her dizziness unless these thyroid nodules are causing that. So my first answer is usually unlikely that the dizziness is due to the thyroid nodules, but we'll look at the nodules as its own problem. This, of course, is the problem of the incidentalloma, the finding of a tumor of one kind or another incidental to other medical care. How often does this happen? Well, as we said before, anywhere from 20% to 2/3 of patients will have thyroid nodules. And so it happens very, very frequently, and the older we are, the more frequently this can happen to us. Thyroid cancer is found in about 4% of all the nodules that are found incidentally. For those of you that have been following along, that's about the same percentage of all thyroid nodules, about 4%. Incidental thyroid cancers can be invasive in a fifth. They can extend extrathyroidally in a fifth. These are not good signs, but these were incidentally found tumors. They can have lymph nodes positive in the neck in upwards of 1/4 of the nodules. Tumor multifocality may happen in about 1/3. Distant metastases happen at about 1.6 to 2.5%. Again, fairly similar to nodules that you can palpate and that you know are there. And thyroid cancer-specific mortality is about 1%. For all practical purposes, you could transfer all of these numbers to a palpable thyroid nodule, and many of these incidentally found nodules actually are palpable. They just were never felt. So what we do next, knowing that the TSH is normal, is we shift to an ultrasound. So we don't do a radionuclide scan because we're not likely to be finding a benign hyperfunctioning nodule, but rather we're concerned here. So we do an ultrasound, and as we said before, we're going to select out the nodules, if there's more than one, that's most likely to be malignant. And we're going to do that based upon the ultrasound pattern. So this is from the 2015 guidelines from the American Thyroid Association on how to identify nodules to be biopsied to find thyroid cancer. And if we find highly suspicious nodules by ultrasound criteria, we can estimate that 2/3 to 90% of them will have a thyroid cancer. So we can't miss this pattern. Now, hypoechoic nodules that have microcalcifications and irregular borders are suspicious, as are hypoechoic nodules that are microlobulated or have uneven borders, and hypoechoic nodules that are taller than wide, and I'll show you examples of all of these. And if you work with your radiologists, please ask them to evaluate all of these features to try to come up with a cross-sectional estimate of risk of malignancy in their nodule. Other ones with extrathyroidal extension, of course, are going to be suspicious, and those that have irregular margins and suspicious lymph nodes. So let's take a look and see what some of these things look like, because you too can recognize these and help your radiology colleagues if they're not up to speed yet. So here's a microcalcifications. These are these little dots here that are all through this nodule. That is the presence of Samoma bodies. Remember Samoma bodies from pathology. It's a hypoechoic nodule because it's darker than the surrounding normal thyroid tissue out here, and it has this irregular margin that is not nice and smooth or rounded. Here's a highly suspicious looking hypoechoic nodule with these very irregular borders. You can see the tumor growing into the normal thyroid. Here's a hypoechoic nodule that is taller than it is wide. So you measure the transverse view. In the transverse view, you measure the transverse measurement versus the anterior-posterior measurement. And if it's taller than wide, cancers grow that way. Benign nodules typically are fairly round or ovoid. Here's a hypoechoic nodule with irregular borders again infiltrating into the tissue and also going extrathyroidal into the strap muscle around the thyroid. Here's a hypoechoic nodule with interrupted calcifications in the rim, very highly suspicious. And here is a small little thyroid nodule. It's got some irregular border on it, but simultaneously we found this abnormal looking lymph node on the same side. And lymph nodes are typically rather flat, but this lymph node is increased in size and very suspicious for metastatic thyroid cancer into that lymph node. So the high suspicion patterns are what we really want to find most of the time. High suspicion, 70 to 90% cancer rate. Intermediate suspicion drops drastically to 10 to 20% risk. And here's where we're going to find most of our nodules. They're going to be hypoechoic with relatively regular margins like this. Look at that nice margin all around this, 10 to 20% risk of malignancy in a nodule that looks like this. Here's one that's hypoechoic with a regular margin. That's what the typical 10 to 20% risk of malignancy appears to be. Lower risk, 5 to 10%, will be hyperechoic, more intensely echoic than the surrounding thyroid tissue with regular margins, or isoechoic, the same color just with a halo around it to demarcate it from the other tissue. Even partially cystic lesions that have solid components will be considered in this low-risk category, 5 to 10% risk of malignancy. Hyperechoic, with a nice margin around it. Isoechoic, where the echoes here are about the same as in the normal tissue, and then the partially cystic with a solid component is potentially going to be a malignancy, but it's lower risk. There's another picture of solid components that are lower risk. So if lower risk of malignancy is 5 to 10%, there's actually a very low risk malignancy, less than 3%. And those are typically the spongiform nodules. Now, many of the men apparently will not know what a sponge looks like, but all the ladies know what a sponge looks like. So you cut the edge of the sponge and you see this pattern that looks like that. And that would be a very low risk. Okay, and finally, we have actually defined benign nodules that don't require any further attention. And those will be the purely cystic nodules that we used to get very confused about. But now, we only do fine needle aspiration to make a diagnosis of thyroid cancer in those with highly suspicious and intermediate suspicion at the 1 centimeter level. So 1 centimeter or greater should be biopsied to find clinically relevant cancers. If we have a low suspicion, we'll wait until it's 1.5 centimeters. Very low suspicion, those spongiform nodules, about 2 centimeters. But if it's purely cystic and we think it's benign, then we will not in any way biopsy that. The results of the biopsy will be distributed in the following manner. We have categories here. The non-diagnostics, meaning there's not enough cells to make a diagnosis, have a relatively low risk of malignancy, but typically we will repeat that to get enough cells to make a diagnosis. Those that are benign have less than a 3% risk of malignancy, and we will typically follow clinically. Atypicals, as well as follicular neoplasms, have increasing risk of malignancy on the cytopathology. And we will be doing redos or lobectomies or total thyroidectomies based on that. And a smaller percentage actually are diagnostic of malignancy. So frequently a total thyroidectomy may be indicated. If we find this intermediate, indeterminate type, so if it is indeterminate in the United States, we're looking at mutation modeling to see if we can identify thyroid cancers. gene expression classifiers to find benign thyroid nodules, and even microRNAs on smears. So here's what happens when you biopsy a thyroid nodule. If it's inadequate, you will repeat it, and if it is inadequate again, that patient may be pushed to surgery or perhaps followed closely. If you biopsy the nodule and it's benign, then follow-up is all that is recommended, typically with an ultrasound. Malignant biopsies will lead to surgery. However, the indeterminate biopsies may lead to cytogenetic testing now in the United States, or could go to surgery. And if there's a mutation present, then they will go to surgery, possibly a
Dear doctor, your time is up.
Okay. So if the cytogenetics is not positive, then perhaps we can just follow the patient with ultrasound. So I'll stop there, obviously, and thank you very much. Shukran.